Well, thank you very much, Dr. Graham. I'm going to introduce the other two members of a panel. So we're going to have a panel discussion. The first person I'd like to bring up, Dr. Graham talked a little bit about, but this is Dr. Camara Jones. Dr. Jones is the president of the American Public Health Association. She's a senior fellow at the Satcher Health Leadership Institute and Cardiovascular Research Institute at the Morehouse School of Medicine. She is a family physician and an epidemiologist whose work focuses on the impacts of racism on the health and well-being of the nation. As you know, racism and discrimination are certainly components of the social determinants of health. She seeks to broaden the national health debate to include not only universal access to high-quality health care, but also raise attention to the social determinants of health, which also include, of course, things like transportation and education and poverty, and other aspects of equity. As a methodologist, she's developed new methods for comparing full distributions of data rather than simply comparing means or proportions in order to investigate population-level risk factors and propose population-level interventions. You know, as a teacher, and this doctor is a real teacher. She uses allegories on race and racism to illustrate topics that are otherwise difficult for many people to understand. She talks about hoping that her work will help initiate a national conversation on racism and then ultimately result in a national campaign in our nation against racism. I've known Dr. Jones for many, many years. She is one of the most incredibly well-trained folks that I know. From her years training at Stanford University, Hopkins University, and her time as a medical epidemiologist at the U.S. Center for Disease Control and Prevention, Dr. Jones has really been the voice of our nation on health equity for many years. And so I'm going to ask her to come up and join us on the panel. If you give her a great round of applause, please. I'd also like to introduce Margaret Linscott. She's a sophomore at James Madison University. She is our 2014 National Youth Advocate of the Year and sits on the board of the Campaign for Tobacco-Free Kids. She joined her county's chapter at the statewide Students Working Against Tobacco, known as SWAT program, as a freshman, where she first learned about the devastating effects of tobacco when her grandmother died of a tobacco-related disease. To help reduce tobacco use among her peers, she successfully worked to pass a countywide K-12 comprehensive tobacco policy that bans tobacco use on social grounds and at school-sanctioned events off campus. She has also advocated for Florida counties to pass resolutions supporting a ban on candy-flavored tobacco. She's learned to tap into the power of social media to promote Florida's new Not a Replacement tobacco prevention campaign, where youth are encouraged to send selfie statements to tobacco companies, photos of themselves with handwritten signs telling Big Tobacco that they are not replacement smokers, but individuals. Since its inception, Not a Replacement has been featured in 17 magazine, the Huffington Post, and Chelsea Clinton's book, It's Your World. In 2014, she was named the Campaign for Tobacco-Free Kids National Youth Advocate of the Year. And since then, she has worked with various tobacco prevention groups across North America to spread the message of the power of the youth voice and work with the Campaign for Tobacco-Free Kids to implement the Not a Replacement campaign on an international level. Currently, she is attending James Madison University to earn her degree in public policy and speaks at youth advocacy conferences around the country. And I can't think of anyone who could not help but lead us into the 2030s, but Ms. Maggie Linscott. Maggie, if you come up and join us. take the far seat. I wanted to start this conversation by starting some questions from our panelists. And this is for the whole panel. Obviously, we worked very hard to get the Affordable Care Act in place. And now that we have a record number of people with health insurance coverage, I think we can now really zero in on what keeps our communities healthy. How can we make the shift from the national dialogue on health insurance coverage to a dialogue on creating healthy opportunities for all of us? Let me start with you, Dr. Jones.
Well, thank you for that question. And I think there is a lot to celebrate in terms of increasing access to health insurance, although we are not there. And I actually live in the state of Georgia, where we have not expanded Medicaid, which was a key part of the Affordable Care Act. And there are 17, I think, still states, most in the South, where even that part hasn't been done. But I often try to illustrate different levels of health intervention with a cliff analogy. So if I might just very quickly draw in the air an image, first of all, of somebody just walking along, and then whoops, boom, they fall off the edge of the cliff of good health, in fact. And if that were you or somebody in your family, you'd be delighted to find an ambulance there at the bottom of the cliff to speed you on to care, right? That's one level of health intervention. But if we were interested in public health, community health, population health, if this were National Public Health Week that we were launching, we might well ask ourselves, as you just did, what else could we put in place besides just stationing lots of ambulances at the bottom of the cliff? So one thing we could put is a net to keep people from getting crunched at the bottom, even if they've fallen. But nets, as good an idea as that is, have holes in them. Some people might fall through the cracks. We could even make that a trampoline halfway down. No holes in a trampoline. But even if we had a trampoline halfway down that cliff, we might find ourselves with lots of people just bouncing up and down at half functionality, not able to get back to the top of the cliff. So we could say, oh yes, of course, we need a fence at the edge of the cliff to keep people from falling in the first place. But even with the fence, it's going to have to be a strong fence if there's a lot of population pressure against it. So what else could we do as a health intervention? We could move the population away from the edge of the cliff. So clearly I've talked about medical care and tertiary prevention being preventing the complications from the disease that's already manifest. I've talked about secondary prevention, safety net programs, early detection screening. I've talked about primary prevention, keeping things from happening in the first place, like immunizations. And I've also talked about addressing the social determinants of health. I'm so encouraged by this Healthy Cities and Counties Challenge. You know, that's about addressing the determinants of health and illness that are outside of the individual, right? Beyond our individual genes, beyond our behaviors. So poverty, housing, transportation, agriculture, education, all of that. But even that cliff, when I've talked about these 4 levels of health intervention, all of them very important, even that cliff hasn't talked about how health disparities arise. And when you think about health disparities arising on at least 3 levels, differences in quality of care received within the healthcare system, the Institute of Medicine in 2002 released its unequal treatment report, documenting at that time hundreds of studies, you know, that were saying, you know, if you come in with chest pain, how vigorously your chest pain would be addressed depends on your race, or how much pain medication you would get if you walked into an emergency department with a long bone fracture would depend on your ethnicity or your race. So there's differences in quality of care, but then of course there's also differences in access to care. We're trying, you know, against resistance unbelievably to increase that, but we all recognize in this room that health is not created within the health sector. So there's a 3rd level at which health disparities arise, differences in the quality of our lives, in our life opportunities, exposures, and stresses. So when you think about those 3 levels at which health disparities arise, and you think about the cliff that I've just drawn, actually, I don't need to be talking about a flat 2-dimensional cliff. Actually, we are dealing with a 3-dimensional cliff. And at some parts of the cliff, there might be an ambulance there, but it might have a flat tire. So it might be slow or go off in the wrong direction, or maybe there's no ambulance, nor net, nor fence, And usually at those parts of the cliff, the population is being pushed closer to the edge. So I would like to expand in terms of the Healthy Cities and Counties Challenge. Not only do we need to be about moving the population away from the edge of the cliff, but we also need to be asking what is creating three-dimensionality in the cliff, what is keeping it that way, and how do we address what I describe not as the social determinants of health, but the social determinants of equity, systems of power that can distribute resources and populations. Because usually at those parts of the cliff where you don't have ambulance, net, or fence, the population is being pushed closer to the edge. How do we address those things like racism, sexism, heterosexism, economic systems like capitalism and the like? And actually, I'll close with this. In my presidential initiative as APHA president, I announced that we were going to launch a national campaign against racism, not because APHA by itself can undo this system, not that I in 1 year as president can do that, but to do some agenda setting and to invite partners and communities to name racism, to ask how is racism operating here, and to organize and strategize to act. So I think that is the opportunity. And I'd love to talk about that more. But.
Thank you. Ms. Linscott.
First off, I'd like to say that it's an absolute honor to be sitting at this table. I think it's safe to say that among the four of us sitting at this table, when I get home tonight, I might be the only one to study for a test. So it's an absolute honor to be here. I've been in tobacco control. I'm a youth advocate for about 5 years now, and I've really seen the impact that it's had on my peers and my family. Tobacco use takes approximately 400,000 American lives each year. However, we know how to reduce tobacco use, how to stop it in its tracks. Multiple research studies have found that we know how to reduce it, from tobacco taxes to smoke-free workplaces to media campaigns or even evidence-based cessation models. And so I'd like to talk briefly about mass media public education campaigns, because I think it's really important in promoting public health. The CDC's Tips from Former Smokers campaign, among those, approximately 1.6 million people who saw that campaign made quit attempts, and nearly 100,000 people quit permanently. And I think that really has something to say about the power of public education campaigns, mass media campaigns, when it comes to talking about public health and trying to keep people from getting sick. Just in terms of the tobacco control movement, the tobacco industry actually spends about $8.8 billion each year to market and advertise their products. So in that place, there's almost this vacuum if we don't have an answer to that, if we don't have some sort of educational piece to get people to quit or to educate them about the harmful effects of those products. But in general, mass media campaigns like the CDC's, I think, really need to be replicated, not just with tobacco use, but with a variety of other health factors. And I think that it can reduce unhealthy behaviors, health behaviors, and really help to promote more healthy behaviors. So these mass media campaigns, I think, are really that next step into really trying to promote healthy behaviors.
Thank you. Dr. Graham.
So I'll take a page from what Camara just said and add a little thing about understanding the importance of societal barriers. And the other day I was asked, what is the one intervention that I think would make any particular community, particularly low-income communities, healthier? And I, as a doctor, I actually think it's education. And the reason I think it's education is because education offers people opportunities to make them economically viable, and all these different kinds of things to realize their full potential. And that allows them to live not necessarily a disease-free life, but a healthier life. And I think there's a difference between not having a disease and being optimized in terms of your health. When I was hearing Camara's story, I was just thinking of my own even personal life story and how early on in life, our mom said, it's the third time talking about her today. My mother said that education was going to be our key out. It turns out she was right. And I think that education allows you to be able to do all the kinds of things you want to be able to do in life, like sit here and have this conversation about a national agenda that you've been a part of in different kinds of ways. So why do I go to your answer when you ask, what is the next step beyond the Affordable Care Act? I do think it is referring to the things that both of you said. It's just how do you make a community more resilient in terms of when messaging, negative messaging might try to have them do activities that are bad for their health, and the antidote for that is education. It might not necessarily be the formal education that I was alluding to before, but it is education in a different format. So I think that the concepts of social determinants of health are particularly important, as we were kind of alluding to before. But if I was going to pick one kind of quiver and arrow to deal with the challenges beyond where we are today, I would say it is education opportunity, which leads to economic viability, which leads to people being able to understand the world better, and more importantly, allows them to have opportunities to have impact.
So I know you talked about structural racism in education and tobacco, and the importance of mass media. What are some of the other social determinants of health? Now, we've got the Healthiest Cities, Counties Challenge going on. I know that Aetna, you also have another community challenge as well, in which you've got grant dollars going out the door for certain determinants and indicators. Can you talk about some of that work, and particularly from a social determinants perspective, what you're trying to hope to achieve through your work?
Yeah, and so, I always, coming from government and then academics and not being here, I always think that the dollars is just a secondary to what you can do to empower people. And so if you can empower them with $1, that's great. If you can empower them with $50, that's great. If you can empower them with $1 million, that's even better. But the real thing that we're trying to get to with all of our investments and our activities is how do we empower people to make better decisions and to live healthier lives. And to do that, you have to make the default easier, and you have to remove all the structural barriers that people face, particularly folks from poor and low-income communities. And so I think all of our grant making is aimed with the lens of equity and with the vision of empowerment and being able to deal with it. Now, the problem is, as Camara alluded to, these problems are very deep. And even when I think about my own life story and all the challenges we've faced, there are things that go to a different depth that you need other things to happen. And this goes back to even when we started the concept of the challenge and how we even came up with this idea and all the other things that different partners have been bringing to the table, including Lee and the leadership of the Focus CEOs for Cities, is this idea of being multi-sectoral. And so to get to the depth of the challenge, you do need to look at transportation, you do need to look at housing, you do need to look at education, which I was alluding to before, and you do need to look at all of these sectors in a multi-faceted approach, and to use the public health term, health in all policies approach is probably the best way. So that's how I view our attempts at a solution, but our attempts have a lot to do with hopefully inspiring people to be able to do other things.
Thank you. Ms. Linscott, can you talk a little bit about your experience on campus and in terms of the fight against big tobacco and some of your experiences there, using tobacco as a social determinant?
Right, yeah. So tobacco is definitely can be a social determinant, but there's also other factors that play into it, if you're more likely to use tobacco. The LGBTQ plus community has a much higher use of tobacco than the general population, and part of this can be attributed to the fact that they're directly marketed to by the tobacco industry. But on campus, and actually, if I could go even further back to when I was in elementary school, I actually lived in a military family, so I've switched schools approximately 8 times in a variety of different states. And so what this has done for me is I've been able to see how different schools operate in different states. So I went to one school where they had morning yoga and morning stretches every day before class, and really nutritional lunches. And then the next school I went to didn't have any of that, and we had chips and soda. Those were the only things that we could get. And so that type of environment that was cultivated, those 2 different environments, really played a big impact on how the students made healthy decisions and how they made unhealthy decisions even. And so the school with the unhealthy food